Hello and welcome to the session of the sodium discussion part 2. We have already covered the session of the sodium intake, serum sodium detection methods and its normal value in the previous video. You can click here at the I button if you want to see that video, and you can also find it in the description below. This session is to cover the aspect of the hypernatremia and hyponatremia. What is hypernatremia? Hypernatremia means increase serum sodium more than 145 milliequimole per liter, and hyponatremia means decrease in the serum sodium less than 135 milliequimole per liter. Before we go into the details of hypo and hypernatremia, let's learn the terms like isotonic, hypotonic and hypertonic solution. Isotonic solution is made up by adding a 9 gram of salt to 1 liter of the water. This is the optimal tonicity of the solution required to maintain the cell volume and the function. Here the cell remains healthy. Hypotonic solution is simply a pure water in which no salt is added. Hypotonic solution means low sodium outside of the cell. The extracellular fluid osmolality is decreased, and that allows the flow of water into the cells and expand the intracellular volume and the cell swell. Hypertonic solution is when more sodium is added to the solution, like 18 gram of the salt in 1 liter of the solution, which increases the plasma osmolality. Increase in the plasma sodium attracts the water out of the cell, leading to the shrinkage of the intracellular volume and the cell shrinks. This picture shows the microanatomy of the kidney. Now we discuss the sodium reabsorption in the kidney. Okay, this is the Bowman capsule forming a glomerulus where all the electrolytes and low molecular weight solutes are filtered in the kidney. As they pass through the different tubules, they are reabsorbed to the blood to maintain the balance of these electrolytes and solutes in the body. For the sodium, 99% of which is filtered by glomerulus, is reabsorbed in the proximal convoluted tubule, in the loop of Henle, in the early distal convoluted tubule, and in the late distal convoluted tubule and collecting duct. There are different mechanisms that reabsorb the sodium according to the tubules. In the proximal convoluted tubule, sodium and amino acid transporter, sodium dependent glucose transporter and sodium hydrogen exchange transporter helps to reabsorb 65% of the sodium filtered by glomerulus. In the loop of Henle, sodium potassium chloride co-transporter help to transport 20% of the filtered sodium. This pump is inhibited by loop diuretics. In the early distal convoluted tubule, the sodium chloride co-transporter helps to reabsorb 10% of filtered sodium, and this pump is inhibited by thiazide diuretics. In the late distal convoluted tubules and in collecting duct, the epithelial sodium channel and the sodium potassium pump helps to reabsorb remaining 4% of the filtered sodium. The epithelial sodium channel pump is inhibited by amiloride, and the sodium potassium pump in collecting duct is inhibited by spironolactone diuretics. Let's discuss hyponatremia. Hyponatremia means serum sodium level is less than 135 milliequimole per liter. The moderate hyponatremia is equal to serum sodium is between 125 to 129 milliequimole per liter. Severe hyponatremia means serum sodium less than 125 milliequimole per liter. The symptoms of this hyponatremia having a mnemonic called salt loss. Let's see what is salt loss. S for seizures or headache, A for anorexia, nausea and vomiting, L for lack of energy, low BP, T for twitching of muscles, L for limp muscle or the muscle weakness, O for orthostatic hypotension, S for stomach cramping, S for stupor or coma. Let's learn in detail about hyponatremia. There are three types of hyponatremia: isotonic hyponatremia, hypertonic hyponatremia, and hypotonic hyponatremia. What is isotonic hyponatremia? In isotonic hyponatremia, water content or per unit volume of plasma is reduced. How? Let's see. First cause of isotonic hyponatremia is hyperlipidemia and second is hyperproteinemia. In this situation, the sodium content of the serum is normal, but due to abnormally increase in the lipid and the protein which are constituent of the serum, it leads to hyponatremia. It is called isotonic hyponatremia. In this condition, the plasma sodium concentration per liter of the plasma water is normal, but because of the reduction in the water content, the sodium concentration per liter of the plasma is reduced. The next is hypertonic hyponatremia. In this condition, the osmotically active solutes attract the water out of the cell and diluting the extracellular fluids. Example are hyperglycemia, example is diabetes mellitus, and exogenous solutes like mannitol and glycerol. In both this example, the presence of osmotically active solute confined to the extracellular compartment attracts the water out of the cell, diluting the extracellular fluid and lowering the sodium concentration. Despite a reduced sodium concentration, osmolality is normal or increased. This state is called hypertonic hyponatremia. And the third is hypotonic hyponatremia. When isotonic hyponatremia and hypertonic hyponatremia have been eliminated, it may be concluded that the disproportionate water retention has occurred and that hypotonic hyponatremia is the result. So the causes of the hypotonic hyponatremia are renal failure, congestive heart failure, liver cirrhosis, diuretics, primary polydipsia, and SIADH. Let's learn in detail about hypotonic hyponatremia. So when you see a patient of hyponatremia, first exclude hyperglycemia and the other causes of non-hypotonic hyponatremia. And when hypotonic hyponatremia is confirmed, then ask or observe, is there any acute or severe symptoms are there? If the answer is no, then conduct the urine osmolality. If the urine osmolality is less than 100 milliosmol per kg, consider the cause of hyponatremia being primary polydipsia and low solute intake. And if urine osmolality is more than or equal to 100 milliosmol per kg, consider doing the urine sodium. Further, we discuss the urine sodium in detail in the next slide, but let's first see what happens if acute or severe symptoms are present. So if severe or acute symptoms are present, then consider immediate treatment with 3% hypertonic saline 100 ml over 10 minutes into 3 as needed. Now let's see the urine sodium. If the urine sodium value is less than 30 millimole per liter, then effective arterial volume would be low, and the causes of this low effective arterial blood volume are heart failure, liver cirrhosis, nephrotic syndrome, diarrhea and vomiting, and remote diuretics. If the extracellular fluid is expanded then the causes are heart failure, liver cirrhosis, and nephrotic syndrome. And extracellular fluid compartment is contracted, then the causes are diarrhea and vomiting. What is effective arterial volume? Effective arterial volume refers to the adequacy of arterial blood volume to fill the capacity of arterial vasculature. It seems like that if extracellular fluid is expanded, then this should be normal, but it is not like that. In these three type of situation, due to the different mechanisms, the effective arterial blood volume is low in spite of extracellular fluid is expanded. Let's see if urine sodium is more than or equal to 30 millimole per liter. If the patient is on diuretics, then consider the diuretics as a cause of hypotonic hyponatremia. And if the patient is not on diuretics, then check for if extracellular fluid is contracted, then the causes are vomiting, primary adrenal insufficiency, renal salt wasting, cerebral salt wasting, and if the extracellular fluid is normal, then consider the SIADH and secondary adrenal insufficiency as a cause of hypotonic hyponatremia. Let's discuss about hypernatremia. Only rarely does hypernatremia as a result from excess of the sodium. It is virtually always due to the deficit of the water. Most of the cases of hypernatremia seen in the hospital practice are elderly patients with varying degree of impairment of the mental function, and mechanism is either an impaired thirst drive or debility with inability to obtain water. If the amount of the water provided is inadequate, if insensible losses are increased by the fever or high environmental temperature, the hypernatremia results. The symptoms and the sign. The mnemonic for this is shy MLD fried CCD. Let's see the full form. S for seizures, HY for hyperreflexia, M for muscle twitching, L for lack of energy, T for thirst, F for fever and flushed skin, R for restlessness, I for increased blood pressure, E for edema, D for dry mouth and skin, C for conclusion, C for coma, and D for death. The treatment for hypernatremia consists of administration of the solute-free water to restore the plasma sodium and osmolality to the normal. The important points to remember from these videos are the reference range of the serum sodium is 135 to 145 millimole per liter. The hyponatremia symptoms and sign mnemonic is salt loss. Critical hyponatremia when serum sodium drops below the 125 millimole per liter. Treat acute and the severe hyponatremia with 3% NaCl 100 ml bolus IV transfuse over 10 minutes into 3 as needed. Hypernatremia is usually due to the deficit of the water. Hypernatremia symptoms and the sign mnemonic is shy MLT fried CCD. These are the references for this video. Hope you like it. Thank you and see you in the next video.